Today we'll discuss a beta blocker overdose patient, the pharmacological treatment, and some other considerations about the beta blockers. When a beta blocker overdose patient comes to the hospital, especially to the emergency room, we don't have any specific laboratory test or a biomarker which can clearly tell us about the beta blocker intoxication. Usually these patients, when come to the hospital, they present with their different symptoms ranging from weakness to dizziness to complete loss of consciousness. Actually, in general, both the beta blocker as well as the calcium channel blocker overdose patients have similar signs and symptoms. And interestingly, both the for both the beta blocker as well as calcium channel blocker overdose, the treatment is more or less the same. Now, in order to understand why the treatment is same for both the beta blocker as well as the calcium channel blocker overdose, we need to look at the briefly how these drugs work. Since the beta blockers and calcium channel blocker, they control the flow of the calcium going inside the cell. The calcium channel blocker, as the name itself suggests, they block the calcium channel, keep the calcium out, whereas the beta blocker block the L-type calcium channel opening, by acting on the beta receptor. In a way, you can say both the beta blocker and the calcium channel blocker are more or less, I'll say even beta blocker are indirectly acting as like a calcium channel blocker. Ultimately, basically, the preventing the calcium from being able to go inside the cell and do its job. We'll discuss a patient like relatively in mid 50s, a 53-year-old female who was brought to the emergency room by the EMS, who intentionally consumed the entire 60 tablets of our metoprolol tartrate medicine, which were recently filled. When she was brought to the hospital, she was very lethargic, oxygen saturation in like 92%. She was put on nasal cannula at 4 liters per minute, and she was not responding very well to the commands. Her vital temperature 97.4 degree Fahrenheit, heart rate was like a little low, 40 beats per minute, blood pressure 55 over 40 millimeter of mercury, and the respiratory rate was like 12 breaths per minute. In the hospital, they gave 1 liter bolus normal saline and atropine 1 dose 0.5 milligram IV push. So once they gave the patient these two atropine and the normal saline bolus, her heart rate went up to 55, blood pressure increased slightly to 75 or 58, and she became slightly more responsive, more stable, but her blood pressure and heart rate are still low. If you look at the numbers, that means her response to the atropine and the normal saline bolus was not adequate enough. So so she was given another dose, given 5 milligram glucagon IV push. So five minutes later, after giving the glucagon, there was no further response seen in the patient. So the medical team approached the pharmacist to find out what could be the next treatment option in this case. Should you give additional glucagon IV bolus, or should you give calcium chloride, or start the patient on intravenous lipid emulsion therapy, or start the patient on insulin and glucose therapy. Something to briefly discuss about the beta blockers. Even though we have a huge list of beta blockers available in the market, but in terms of their efficacy and side effects, they're not the same. Some beta blocker like atenolol, carvedilol, labetalol, metoprolol, oxpranolol, pindolol, or propranolol and timolol, these are more lipid soluble. So what it means is that they can easily cross the blood-brain barrier and penetrate into the central nervous system. So they can alter the patient's mental status very quickly. Whereas calcium channel blocker, usually those patients don't have, they don't complain much of the altered mental status, where the beta blocker patient you'll notice more of the altered mental status. Some of these beta blocker like acebutolol, betaxolol, oxpranolol, propranolol, they also inhibit the sodium channel conduction, so they act like a membrane stabilizing agent if in a way, so when the propagation of the action potential is impaired, this can lead to certain kind of dysrhythmias, or can prolong the QRS interval in the EKG. There are some drug specific factors for the different beta blockers. Some beta blocker like acebutolol, oxpranolol, pindolol have the intrinsic sympathomimetic activity. These agents, instead of blocking the beta receptors completely, they block the beta receptors incompletely or partially. So I'm going to deviate a little bit slightly from the actual mechanism in order to explain in terms of like day-to-day life. So imagine when you work as a professional, we all are qualified professional and are supposed to be equally competent and do our job properly. But in the real world scenario, sometimes we come across some colleagues or some people who are not as efficient as the other co-worker, and but they still counted as a member of the team. So since they are less productive, they become counterproductive, in other words. But this counterproductive property can be sometimes useful in a way. For example, in a way they are like they act like a partial agonist instead of like a full agonist. So if they are doing their job partially, so instead of blocking the beta receptor completely, they will be blocking the beta receptor partially. So the heart rate and the blood pressure may not go that much down. In a way it's a good thing, in those type of scenario. So if the patient has this type of beta blocker which have the intrinsic sympathomimetic activity, overdose of these beta blocker may not lead to very severe bradycardia or very severe hypotension. Some of the other beta blocker like sotalol has a little different mechanism. They possess they call Vaughan-Williams class 3 antiarrhythmic property. They act like a potassium channel blocker, and this can lead to QT prolongation, and can lead to can put the patient at increased risk of torsades de pointes. Now some of the things when it comes to beta blocker treatment consideration is the initial supportive care recommendations are similar in both beta blocker as well as calcium channel overdose scenario. For example, giving the intravenous atropine anywhere from 0.5 milligram to 1 milligram is to increase the heart rate, and giving bolus IV fluid like 1 liter normal saline. Those are standard initial supportive treatment. Now why IV fluid bolus in such patient is just taking beta blocker, patient not losing any fluid or any, but they are not hypovolemic, so why we giving the normal saline into this patient? The idea is to increase the circulating volume so that the blood pressure can go up a little quickly. The other treatment option depend upon the severity of the overdose. Once you give the atropine and the fluid, generally, what are the next treatment option depend, like as I said, like how much overdose of the beta blocker the patient has consumed. Generally, IV glucagon either as a bolus or as a continuous infusion is given, is used, or the other, you can give IV calcium injection, or you can use the vasopressor like epinephrine, norepinephrine to raise the blood pressure. Can use high dose intravenous insulin and glucose, or IV lipid emulsion. Those are some of the other options when it comes to the beta blocker overdose. Now after we give the supportive therapy, IV glucagon is typically the most recommended therapy. Basically, IV glucagon is considered as an antidote. In adults, usually anywhere from 3 to 5 milligram or up to maximum of 10 milligram as a single dose is given as a IV push. You give the glucagon, wait for about 5 to 10 minutes. If there is no response or very little response, then you can repeat the bolus dose. Typically, the effect of glucagon is seen within couple of minutes, like anywhere from 1 to 3 minutes, and the peak effect of glucagon usually occurs around like 5 to 7 minutes after the administration. The mean arterial pressure goal in this patient is generally around 60 millimeter of mercury, and once you give the glucagon, keep track of how many milligram of glucagon you have given to the patient in the form of bolus during 1 hour time frame, and this would be your effective glucagon dose. Actually, you can maintain that effective glucagon dose per hour as a continuous infusion. Generally, they say big range, glucagon range depending upon patient to patient, generally anywhere from 1 to 15 milligram per hour dose has been used glucagon in this patient. And it all depends how much beta blocker the patient have consumed. Now, but one thing you need to keep in mind, since glucagon is a protein hormone, what it means is they can lose their effectiveness over time because of the tachyphylaxis, and also the glucagon can cause nausea and vomiting. So when you give the glucagon, consider giving the Zofran or ondansetron along with the glucagon to prevent any nausea, vomiting occurring because of the glucagon. Slight mention about the glucagon is like it activates the adenyl cyclase at a site which is independent of the beta adrenergic agent, so this can cause increase in cyclic AMP, and elevation in cyclic AMP increases the intracellular pool of calcium available for release during depolarization, and thus it augments the contractility of the muscle. the successful use of glucagon to manage the beta blocker toxicity has been documented in many case reports. However, there are no controlled trials available in human being to establish any specific dose for the glucagon. When it comes to treatment recommendation, since in our patient, the patient under question, the patient was given atropine and IV fluid bolus initially, and patient showed some response. So in this case, all the other options, as I mentioned earlier, giving the glucagon, additional glucagon, would be a better choice. How about the calcium chloride? Would not be a better choice at this time, because we don't know if the patient has a central line or at this time or not, because calcium chloride is highly irritating, and so if you want to give calcium chloride, make sure patient have the central IV access available. When it comes to IV lipid emulsion or the high dose insulin or glucose therapy, those are also valid options, but this patient was responding to glucagon, so I don't think those are the better option at this time to consider using the insulin or the fat emulsion. Remember, patient had not failed the glucagon therapy. So if the patient had failed the glucagon therapy, then we will consider switching over to higher, more potent therapy like IV lipid emulsion or the insulin glucagon therapy in this case. Thank you.